Hey everyone. I know we've got folks who are going to start to join over the next couple of minutes. Really excited to have you all on. We're going to get started in a few minutes to give folks time to get on and get situated in the Zoom. One thing that I like to do is while folks are settling in, I know we're seeing participants start to come in. Feel free to just drop in the chat where you're calling in from and maybe just your role at your company. Super helpful for Todd and I to know who we're talking to, who the audience is in the chat, so we can get a sense for that and just say hi. Todd, where in the world are you right now?
Hey, I'm still working from my home office today in central Illinois, just outside of Peoria, Illinois, and nice. My hometown of Morton. So, you know, if anybody eats pumpkin pie for Thanksgiving, Morton is known as the pumpkin capital of the world. Most of the 90+% of the canned pumpkin comes, right out of here. So if you're eating your pie, you can think of me.
You know what? I absolutely love that. As a huge pumpkin pie fan, that's a great stat for me. Kristen, welcome. Super excited to have you on. Todd, you might even know Kristen or know of her. She ran the New Jersey State Health Plan, over 800,000 members. Wow. Kristen is, I think, a thought leader in her own right. Tammy, welcome. We've got, let's see who else we have coming in. Tammy's in Irvine, California. She is the CEO at Technology. Tammy, welcome. Thank you for joining us. Carlos, thanks for checking in. Carlos is VP of Human Resources at YMCA in Long Beach. Very cool in the office. I'm not too far away from you right now, Carlos. Hey, Carly. Thanks for joining in. Coming in from Salt Lake City. I'm Carly. I'm based in Park City, Utah, often, so not too far away from you. Well, good stuff. Why don't we get started? Glenn, thank you for joining from NavMD. Excited to have you on. Cool. Todd, you ready to rock?
I'm ready.
Let's do it. Awesome. Well, good stuff. I'll kick off with an intro. First off, just thanks so much to everyone for joining us. We've got a really interesting group of folks on the Zoom. We've got HR leaders from around the country. We also have some innovative brokers, consultants, and healthcare executives, which is really cool, kind of from my perspective, because we're seeing folks who are looking at pharmacy management from all different angles. And I'm excited to have this conversation with Todd. Our goal here is to have a thoughtful, kind of focused conversation aimed at providing some real concrete value and next steps when it comes to getting more out of your pharmacy dollar for an employer health plan. And why don't we dive in? I'll start with some quick introductions. I'm Brandon Weber. I'm CEO and co-founder of Nava. And for those of you who are just getting to know us, Nava is a modern benefits brokerage oriented entirely around the mission to provide high quality, affordable healthcare to all Americans. And we're doing that by bringing a new approach to the table. We've tapped into the benefits playbook, technology, and thought leadership of some of America's most admired companies. And we're bringing that playbook to small and medium-sized employers, many of which are, folks on this call, in a simple, easy to deploy benefits offering. And the title of today's conversation is RX Management 101. What we're really focused on today is kind of two fronts. I want to walk away with first just deepening your understanding of RX and PBMs and kind of why they matter to health plans. And then also to provide you with a couple of takeaways around just concrete strategies that you can use literally today going into your upcoming renewal to start cutting pharmacy costs like some of America's largest employers are doing. Also, just one quick kind of housekeeping item. We love to keep this interactive, so feel free to drop questions you have in the chat. We'll try to answer them either in situ or at the end, or even afterwards. We'll do a follow-up. And before we dive in, I'm super excited, and we are all fortunate to have Todd Bisping as my partner in this conversation. Quick background on Todd. So Todd today serves as Global Benefits and Health Manager at Caterpillar, putting him at the helm of benefits for one of the world's leading manufacturing companies, with over 100,000 employees kind of, in that organization. Todd is also just a true thought leader in the benefits space. When I first met Todd, it was just absolutely clear to me that he's got a passion and a track record for cutting financial waste out of benefits programs, out of healthcare costs. And one just fun proof point to that, his team has kept their healthcare costs flat for basically the last 15 years, which is just a truly remarkable feat, as probably most folks on this call can attest to. We're also super fortunate to have Todd on our Nava Benefits Advisory Board. So bringing Todd's expertise out to kind of the market of small and medium-sized employers. So Todd, thank you so much for joining us.
Great to be here today, Brandon.
Yeah, well, awesome. Let's dive in. I want to start by setting the stage with some data about the magnitude of pharmacy and spend in our employer-sponsored health plans. Kind of three stats that I'll throw at you. So we're spending almost $360 billion on drugs, on pharmacy, on pills in 2020, and that is going up just about 6% year over year, with specialty pharmacy actually exploding, doubling or tripling that trend increase. And now, if you're a typical family, this just came out a couple of months ago from Milliman. If you're a typical family, you're spending 22% of your healthcare spend is now on pharmacy. This is a big chunk of what we are spending our healthcare dollar on. And as we'll talk a little bit more about and kind of dive into, it's also a space that is just kind of rife with fat to trim and opportunities to just be more performant in terms of how we actually spend those dollars. So that's kind of the backdrop. Todd, maybe for folks on the call who don't have as deep of an understanding of PBMs and their role, can you describe the role of a PBM for an employer and why they matter?
Yeah, happy to, Brandon. And, as I go through today, I know we have a variety of different folks on the call here who have a lot of different experiences. And so, I apologize if some of it's basic, but I also apologize if some of it's something you haven't heard before. But hopefully we can find something here that everybody relates to. But most companies, have a PBM or a pharmacy benefit manager who does a lot of the work in managing your prescription benefits. They can have call centers for your employees to call into. They adjudicate your claims. They design your networks. They set up your formularies. All the things that go into your prescription drug plan, they're the ones who are facilitating that and making it happen. When they first started out, they were really just a claims adjudication platform, but they've really expanded the scope of what they do over the course of the last couple of decades into basically, wall-to-wall pharmacy management for most companies in the country.
Yeah, and I think I think one thing that maybe kind of doesn't really land for employers and HR leaders when we talk about this is that the vast disparity in cost for any given drug, the vast disparity between generics and brand, all of that is governed by this three-letter acronym, the PBM, that is working with every single employer here. They're an incredibly important kind of stakeholder in the employer-sponsored healthcare program. Maybe unpack a little bit more, kind of, Todd, from your perspective, what are some of the problematic things that PBMs do that our employer audience might not be aware of when it comes to how they work with them?
Yeah, and so in a lot of places, right now PBMs are getting a bad rap, and sometimes it's justified, and sometimes it's doesn't. They're a business like anybody else trying to maximize their revenue, and they do a pretty good job of it. They're pretty right now.
Very good at it.
But sometimes some of that stuff is at the expense of us as plan sponsors or our employees, because they're running their business to optimize their profit sometimes versus what we do is what we would want them to do, even though they're acting on our behalf. So a couple of examples that are pretty common that you see is that they'll design their formularies or how they place drugs on access to your employees based on the rebates that come in. And while rebates are an important part of the overall value of what we're paying for drugs, we really don't want to choose to optimize on rebates, because that's just one of the ways the pharmaceutical manufacturers incent people to use their drugs. And they have a lot of relationships with the PBMs. And so sometimes they design those rebates in a way that doesn't optimize our value, but maybe optimizes their value. And so rebates is always an area that we're pretty skittish about. Wish they didn't exist in the world sometimes, but there's a valid reason for them, and we want to optimize them where we can. But that's one of the things that, a lot of times people don't have maybe a deep enough understanding of how that all works and how they end up putting things on different parts of the formulary.
Yeah.
You know, another thing that I think is pretty common, it's maybe not as common as it once was, but a lot of people were unaware of this, is, you know, we refer to it as spread pricing. So in other words, if you think about what you're asking the PBM to do, you're really saying, hey, I have these claims, I want you to adjudicate them for me at a price. We have contracts with people to do that. Well, you know, PBMs come in with lots of different contract options and models for people. And one of the things they'll do, and sometimes they'll say, hey, we'll just do this for free for you. You know, we'll make our money elsewhere in the supply chain, no administrative fee for you. But almost in every one of those cases, that means they're doing spread pricing. And what do I mean by spread pricing? So let's just say that when one of your employees uses a prescription drug, it costs $1. Your company then, is the plan sponsor, pays to the PBM, because that's what they have to pay the pharmacy on your behalf. However, sometimes the PBMs have contracts with the pharmacies for that drug where they only pay them 80 cents. And so that's the difference. There is the spread. And in other words, they're serving as nothing more than a middleman there to say, hey, we agreed to sell it to you, and we're going to meet all our requirements to you as a plan sponsor in our contract by charging you $1 for this. But hey, over here on the back end, we have a different deal with the pharmacies we're reimbursing, and we're only going to give them 80 cents. And to me, that's very problematic. I mean, there's really no value in that process there as far as I'm concerned. And, you know, if you have a contract that says, hey, we have a no administrative fee contract, those are almost, it's not they're fun to brag about to your boss maybe and say, we're not paying anything for this, but in reality, it's costing you in the long run. And so that's a couple of pretty common things that, you know, you hear about in the marketplace that PBMs do that aren't my favorite things. They're not illegal, but they're just not the most optimal way for you as a plan sponsor to optimize your spend.
Yeah. And I think one of the things that we're trying to accomplish on this call is to show mid-sized employer HR leaders and CFOs that they have control over this mechanism of their plan as a plan sponsor, and then give them some kind of easy, kind of quick win, like early lever tactics to pull to start seeing real financial savings. So I'm going to keep banging on that drum, because I think what a lot of folks say is they're like, PBMs, you know, Todd with his 100,000 employees and Caterpillar's kind of might in the marketplace can go do magical things, but I can't as a 250 life employer. And we have proven that that is not true, that you are able to do that. So before we get into maybe those levers to pull, Todd, when you're thinking about PBMs and looking for kind of the right fit, what are the specific characteristics that you're looking for there?
Well, as you can imagine, you know, as we go through a process of an RFP or something like that to select one, we've got a bunch of criteria. But if I'm talking about more at a macro level, the things that, you know, would be table stakes for me that I just kick people out if they don't have, the first one is basically flexibility. I mean, PBMs can have a reputation of kind of being bullies and just saying, hey, here's how we do it, sign up for this, and then, you know, take it or leave it kind of stuff. But that doesn't work in my world. I need someone who wants to be more of a partner with me and work with me to help optimize what I want to do, because I like to do a lot of unique things. And I need to find someone willing to do that. And they're not all always willing to do that. And so I'm always looking for someone who provides me that flexibility to do things in a way that I want to do business with them. Because to me, that's one of the biggest flaws that we as plan sponsors do in the whole healthcare spend in general, is that we forget that, you know, we all have the money that they all want. And so we act like they're doing us a favor or something, and we have to just do whatever they tell us. But in reality, my motto is, I have the money, you want the money. And if you want my money, here's what you have to do. And part of that is flexibility. The second half of that, what I always look for is that their willingness to be transparent. And by transparency, I mean clear and the ability to validate where all the money goes and how it goes and what the different revenue streams are that they have. Because, you know, some people might be surprised by this, but, you know, the only revenue stream for PBM is not just what they get from us. There's lots of revenue streams that come in. We talked about one of them briefly in rebates, but there's more than that. And so I've talked to a lot of companies over the years that said, hey, I'm not worried about transparency. We've got 100% pass through rebates with our, you know, PBM, so we're all cool. And I always kind of think to myself, no, you're not, because the PBMs can adapt quicker than we can. You know, 100% pass through rebates was not a thing, you know, a decade ago. it's very common now, but so what do? They adapt. There's different kinds of fees now that where they have with the pharmacies or the pharma manufacturers, market placement, marketing fees, you name it. There's lots of different revenue streams. And so I just want to know, you're in the business to make money. I want you to make some money as a partner. I just don't want you to make too much. And so I really value transparency, and I make sure that kind of language, I have language in all my contracts that allow for my access to that kind of data.
Anything else that you're looking for?
And I always say that, depending on the size of your staff, and if you're a one-person shop or a large shop, it's tough to be an expert in all this stuff, especially, in the contract language. And that's what really, I say it's important to find someone that you trust that's not your PBM. A great example is, Brandon, call him, he's a partner with Nava here. And that's the kind of people you need to be finding to align yourself with, that you can get information that is not tainted by their own business model. And that's a big challenge that people have, even in the consulting world. There's so much stuff that goes on you just got to find a partner that you're really comfortable to trust. I can remember one time I was at a meeting with a bunch of the large consulting houses, and some of them that have their own models and their own buying groups that they run. And so they were asking for questions, and I just said, raised my hand, and I said, do any of you receive any form of revenue or kickback from the PBMs or pharmacies when you place business with them? And oh boy, that wasn't a positive. That wasn't a popular question.
Yeah.
Because in reality they do. And so, to me, that's problematic, right? Where I have a situation now where I'm paying someone to help me make decisions. At the same time, they're getting paid by the people I'm trying to help them protect me from. And so that's a long way of answering your question is, find someone to trust that that's really going to give you information that's to your benefit and nobody else's.
Yeah. 100%. I think I want to hit, before we get into the levers, just one last question. I want to talk about fully insured versus self-insured, because again, so many of the folks on this call, they're fully insured, 250, 500 life groups. How does your funding arrangement kind of impact maybe the role of the PBM and kind of the levers that you can pull?
Yeah, I'm glad you asked that, Brandon, because that's a question that comes up, quite often, especially when I'm talking to the small to medium-sized businesses. Is, large companies like Caterpillar are typically full self-insured. And so that means every penny I save here is a direct correlation to a penny on what I'm going to be paying out as a self-insured company. And so it's an immediate one-to-one ratio. If you save a penny, you make a penny if you're really self-insured. Fully insured is not quite that clear, but the misconception is, well, I can't do anything because I'm fully insured. In reality, it's just a little more delayed benefit when you get more aggressive and active in how you manage it. Because I don't have to tell you, you're paying a premium for that fully insured product. And what is that premium based on? It gets adjusted based off loss ratios and all the things like that, right? And so if you can do a better job controlling your spend, even if it's fully insured, that's going to come back to you in better premiums and lower loss ratios that allow you to not take such a hit all the time. And so it's a misconception to think that, oh, I'm fully insured, so my hands are tied. Now, is it a fair statement? Maybe you don't have as much influence as I can have at Caterpillar? Of course not. But that's some of the work we're trying to do even here at Nava, to bring some of these kind of protocols and some of these things to everybody, because it's really a value question that we all should be able to take advantage of. Yeah,
absolutely. I think that for me, the kind of summary there is like fully insured employers still, A, you've got a PBM, B, you can change your relationship with them, and you can do some of the things that we're going to talk about to put yourself in a better position in terms of your actual cost. So with that as a backdrop, maybe let's talk about how mid-market employers can save money on their RX in their upcoming renewal, and really focus on kind of where the low-hanging fruit lies. So what are the first things that that they should be tackling from your perspective when it comes to lowering RX costs?
Yeah, Brandon, you're hitting here on one of probably the top 2 or 3 questions I get consistently when people call and ask me for my opinion on different things. And this is one of them is, I don't know where to start or what to do. And it's a fair statement to say that if you look at the portfolio of things that, we do now at Caterpillar, there's a lot. You can't just turn everything on at once, right? No one can do that. We didn't do that. No one can do that. So where do you start in this space? And if I think about it, the two things that I tell people that you could tackle first to start dipping your toe in the water are, first of all, I say, there's a lot of money being wasted just in your PBM contract language. There's a lot to talk about there, I guess. But I mean, my point is, the PBMs write the contracts. That's what they do every day, all day. And you do it once how often? Every year, every 3 years, depending on what kind of cycles you use for renewals for vendors. And so they really know how to write it in a way that benefits them. And so if you don't catch some of that stuff, you're going to be in trouble. The second thing I would say that, a lot of people are antsy about doing or nervous about doing a little bit that doesn't need to be is formulary management. To start dipping your toe into how and how you cover things on your drug formulary that you make available to your employees. And this, again, 10 years ago was maybe 10 or 12 years ago was a non-issue, but we really started doing it a little before that, and now it's pretty common, and so it's not unheard of, and it's also a way that you really can drive more value, not only for your company again, but for your employees. And it's a win-win. So that would be the two things I throw out that I think are the quickest and that you could start on and be able to still make some pretty solid savings.
Yeah, let's talk about that. So first one is kind of level up or tighten up your PBM contract language, which is probably going to sound really scary to an HR leader who at a kind of wearing multiple hats. And then the second one is level up your formulary for your PBM. So why don't we unpack that first one? What's important about the PBM contract language, and what can we do to level it up, if you will?
Well, again, Brandon, as you probably know, and the people on the call, you could probably spend the whole hour just talking about how to put together each of these topics on their own. I was going to talk, again, conceptually, some examples that people maybe don't think of or haven't thought of. I would say at a high macro level, number one, I don't want to act like I'm accusing someone of something, but I think some of these contract terms are purposely nebulous, purposely lacking clarity, or written in a way that can result in multiple interpretations. They're just not precise enough, I guess is the word I'm trying to say. And then what happens is you're just now, you've got your contract and you're off running your plan. And the PBM is the one who's making sure that they're following the contract and meet the guarantees, the rates, everything they put in there for you. Okay. And so they're the ones who are doing all that math. You're not doing that math. And so they're then applying all these terms and guidelines in the contract is how they interpret them, if there's any room for interpretation in it. And that's what we see happen a lot. So what kind of things could that be? Some of it might be shocking. It's like, it's simple as, how do you define a generic drug? Well, that sounds like a pretty straightforward one, doesn't it? Guess what? It's not when you in the terms of a PBM. And if they've given you some kind of rate guarantee of an AWP minus something, they're going to meet that bar. What they put in that basket of drugs to calculate that is critical as far as what they're going to deliver for you. And believe me, if they promised you AWP minus 70, they're not going to give you AWP minus 80 almost never. They're going to come in at 80. They might beat it just to say they beat it, but they're not going to. They're going to arbitrage wherever they can across their book of business to maximize the revenue that they have to pay out and give. So, that would be, one kind of thing I would say is that simple contract definitions. The definitions in a contract are a big one. And then to some of the things, Brandon, I would say maybe around, like I kind of referenced is what do you put into these guarantee calculations, right? How you do that, what counts, what doesn't count, what's in the basket of drugs you're guaranteeing me on, what things are you throwing out, and how's that all happening? And so, because again, that's going to be key in what they deliver to you. Because don't think that the contract they have with you is just the same one they have with everyone. Don't think that what they pay pharmacies on your behalf is what the same they pay on everyone. They might have a checklist for every pharmacy or every contract they do for a different pharmacy. And that's a couple things. I could throw a few more out if you want me to, or if you have any questions on that, Brandon, I'd be glad to.
No, I think, I mean, those resonate. I mean, maybe just to give folks a sense for, impact, like what is, what have you seen as kind of the potential impact on just overall on healthcare spend, and tightening up contract language, making it less PBM favorable?
Since this question comes up for me a lot, and I've helped a handful of companies over the years along this path, because I'm passionate about taking waste out of healthcare in general for our country, is that I've seen probably an easy answer would be that if you go in there and get your contract tight, that a lot of companies save 10% off the top. Just by contract, just getting their language tightened up. It's easy for me to say 5 to 10% and feel pretty comfortable about it. Now, again, I hate to make statements like that because each contract is a contract, and and they're all written differently, and maybe your contract's really tight already and there's not that play in it. I'm just saying that if you ask me, 75% plus of the people that I have this conversation with, if we actually pull it out and do a contract review, they'll save that 5 to 10% every time, just on contract.
Yeah, I think we've had similar experience. Just recently going through this process, and this is, I think this is just kind of almost a requirement with every client that we work with. They saved about $225,000 literally off of just language tightening, redefinition around generics. I think one cool question just came in from Scott. He said, "Why would you allow a PBM to use AWP or NADAC pricing to define what they'll charge, given that they're variable terms that allow the PBM to manipulate what they charge the market?" This is getting into 201 level, but maybe Todd, we can just hit on this quickly while it's hot.
No, very insightful question, and thanks for bringing it. And you referenced AWP, which stands for average wholesale price.
Yeah.
In our world, it really means ain't what's paid. I mean, because as the question was framed, it's a very arbitrary number. It really is not an average wholesale price, and it inflates at a rate greater than Medicare. And you're also right, Brandon, by saying this is kind of a 2.0 kind of dialogue, because Caterpillar, we don't use AWP. I would say 99% of PBM contracts today use AWP in it in some way or another, but we do not, because I agree with you that AWP is builds in a false inflationary factor into your contract. And if you really want to go deep and really take all the waste out, that's one of the things I would, as we look at further steps down the path as you walk, that's going to be one of them I'm going to bring up. You can take a lot of these strategic things that PBMs do and take them away from them and say, we want to do it ourselves. One of them being contracting, which allows for methodologies that are not AWP.
Yeah, 100%. Yeah, I think we pulled that off of the topic list for 101, just because I think there's a lot of definitional work there. But Scott, I think you're absolutely right on in terms of moving more toward a pass-through model. One thing that I just want to note, at least in our experience, as we've gone through and said, okay, we are going to, we as kind of your partner are going to go look at the PBM contract and see what we can do to tighten it up, is in our experience, there just has been very minimal member impact. So we can save 5 to 10%, but the impact on the actual member, the human being who is in that employer plan has been minimal to non-existent. Which is just such a big deal, because one of the biggest, there's kind of two big blockers when we talk to HR leaders about, let's go look at pharmacy, let's go break it out. One, it's too complex, I can't understand, I don't have time. And then two, I'm scared to death of doing anything that's gonna put my members into a tough position. So this is kind of low-hanging fruit from that standpoint, at least in my experience. Todd, have you seen anything different, or is that what's your perspective there?
No, I concur, Brandon. I mean, what you described is very accurate. And it's why, as we start people down a path of managing their pharmacy spend, step one is always this, because it's a no-brainer and it's low noise as far as to employees, because the vast majority of the stuff that you're changing is going to not have an impact on employees when you make contract language changes. Yeah,
I want to underscore before we get to the next one, just how much there is in this lever to pull. It's so lucrative that there's an entire class of vendors that all they do is promote negotiating your PBM contract to cut the fat out. And they typically take a percentage of savings, 10 to 20% of savings. You know that there's a problem and an opportunity when an entire small industry of vendors, all they do is go look at your PBM contract and, and interrogate it and kind of cut out some of the fat. So anyway, this is a big one. We're really passionate about this because this is very low hanging fruit. We would argue that every CFO and every HR leader needs to look at this. This shouldn't be your job. This should be your partner's job, your broker's job. We got a question in from Vinay Todd that he said, do you cover generic insulin at tier 1 on the Caterpillar formulary? He's getting detailed, but I just want to see if you wanted to handle that.
No, and so yeah, that's a great question, and so we do. Just because as part of our design, we do look at certain chronic conditions, and we even have a zero at Caterpillar that's a zero copay or co-insurance model, and so we even put some drugs into that. I'm not talking about ones that are mandated by law, due to ACA and stuff like that. I'm talking about we just do an analysis on that. Now it's not a huge number of drugs, but there are some that we want to make the case that we want to remove all barriers for adherence. And so, yeah, so we do.
Cool. Awesome. Let's tackle formulary and up-leveling formulary design, formulary selection. Can you maybe kick off by just kind of unpacking what, an HR leader should know about this, kind of this lever to pull?
Yeah, and there's a lot to unpack here, Brandon. So you may have to rein me in if I ramble on too long here, okay?
Yeah.
But so when you think about formulary management, it's something that's pretty scary for a lot of HR leaders because, when you talk about formulary management, that means putting more definition around what drugs are on your formulary, which ones you're excluding, and how easy they are to access if there's a prior authorization required to access it, or if there's a step therapy where a first drug has to be failed before they can try a second one. And so it's really starting to become a little more invasive in how you interact with your employees on what they can get. And why do we need to do that? We shouldn't need to do that. Doctors know all that, right? They're all the clinicians. And I'm not a clinician. I never claimed to be a clinician. I have clinicians on my team, but I'm not a clinician. But so why would we do that? Well, in reality, if you look at the data, and we've looked at a lot of data, not all doctors, of course, but many of them, it's just not that big of a deal to prescribe the highest value drug. Too often it's driven by what sample they have in their office, what commercial a patient has seen, and they say, yep, that one works for that. I'm familiar with it. There's a lot of reasons why they're not following a high value formulary. And part of that is even just because of the rate of change in the data. It's just a constant churn as we learn more and more things and new things come out. So it seems a bit overwhelming. But what we've found at Caterpillar that is if you'll take the time and do an evidence-based design for how and when you cover different drugs, it's a win-win for your company and for your employees, right? And so, how can it be a win-win? Well, because as we design people through the high value, and that's a combination of cost and quality and evidence-based protocols, then usually you tier things differently. And your employees, by taking the most value drug for them, are going to get the same outcome than they would have got if they had taken maybe the non-value drug, but at a lower cost. And most companies base their tiers on either a co-insurance or a copay. And so by being able to shift your employees to the right tier, they save money. And so it really can turn into a win-win in a hurry if you're willing to do that. I've got lots of interesting examples, but I just don't know how much time you want me to spend talking about this.
Yeah. No, I'll share an example. We just kind of in this last plan year, we had a group where a single drug, which failed the test of value, was costing a single family over $140,000, and a kind of equivalent, outcome drug that they could replace was in the hundreds of dollars in terms of cost to them. And so by essentially kind of replacing those two drugs, giving them the same outcome, saving them their deductible, saving their plan, 6 figures. Just one example of kind of just where it can really hit the pocketbook of the employee and the employer. And I think what we see is 95+% of of the employer plans that we look at in kind of SMB and mid-market category, they haven't even looked at their formulary. Like, I just don't even know what is driving it and kind of how it approaches, let alone make it more high performant. So yeah, so I'd big plus one this. Maybe I'm curious if you kind of like could share like a war story or two of how kind of your experience in what the results have been.
When I again, people ask for examples, and I try to avoid like something I'm doing right now because I don't want this to become a clinical discussion, Brandon. But I like to share things that are maybe subtle science that have happened in the past, to show the different steps. And so one that was just a huge win for Cat and employees was, back 7 or 8 years ago, probably the statin class of drugs for cholesterol was all huge. A lot of them big brand names like Lipitor and all those, and they were starting to move to generics, but not all of them were, and new ones were coming on the market all the time. And so we really tried a little trial with it. We started off with a big education program. We said, let's not be too intrusive here. Let's educate. And so we did an education program around about what you should take, how you should take it, blah, blah, blah. And the savings, teeny tiny. I mean, we didn't see much savings at all. I think employees maybe 100,000 across 100,000 people, and we saved a few 100,000. So we got a little more aggressive, and we thought about how to design this as far as to force them to at least try generic first, and that then started to see a little bit of savings, but it was a pretty rudimentary. So we took it to the final step, and we said, listen, let's design this based on what the current medical evidence shows. We have clinicians helping us do this. And we designed a step therapy process based on their LDL needs. Allowed different drugs to be taken at different times. And the result was overwhelming. It just blew the doors off it. I mean, our employees saved a number in between 1 and 5 million. And we saved between 5 and 10 million. Just in that one class of drugs. So when that's all done, you think, oh boy, that sounds disruptive. You probably hurt people. Guess what we do? We always follow up on the back end to do our data analytics, see what's happening. So we found out adherence went up. Outcomes were a little better. Why? Because now more people could afford the drugs they needed to take. And so you thought you were doing something that might be disruptive, and we were a little nervous that maybe it would, people would just not do it and they just quit taking stuff. It was just the opposite. It was a win-win-win for everybody, but big pharma. So that it was really a great story. And so that's the kind of stuff that I'm talking about that you can find for win-wins for you, your employees, and for your company. Yeah,
it really resonates. And it just underscoring kind of the fact that this is a financial win for both the plan and for the member. And sometimes that additional financial friction is basically the thing keeping them away from adhering to kind of medical outcomes and a prescription that they should be utilizing. So I think when you talk about member impact there, some of this is there is member impact here. We're changing the nature of the formulary. What are kind of how have you guys approached the kind of the member side of things?
Yeah, so this is an interesting story too, Brandon. I mean, because I'm not going to lie, when we first started doing this, our first toes in the water on this, my phone rang a little more than normal. Who the bleep are you to tell my doctor what I can take and blah, 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 blah. And, so that we would walk through the rationale. We'd always say, listen, if your doctor has data that's contrary to this, send it in. Maybe we missed something and we'll adjust. And of course, they went back to their doctors and their doctor never had anything. Their doctor always concur with what we said and put it on the list. But an interesting dynamic happened. Is the first year, 2 years maybe we'd do a class review, and as we'd work through these different classes of drugs, I'd get those phone calls, and then all of a sudden I got my first phone call complaint, and it took me by surprise. It was like, hey, I just want to know why you folks, you made me switch to this other drug, and I saved $600 last year, and my blood work was all the same. Why did you ever let me take that other one? I was taking it for years.
I love that.
Yeah, and so then, so the noise really is plummeted now, because I think people have seen that, hey, by doing this, two things are happening. I'm getting pushed to the high value drug for me.
Yep.
That I'm going to need. And secondly, I'm going to save money right there on that drug. And third, you're not having to change our co-pays or co-insurance because you're managing this cost. This is a win for all of us. And so the noise really plummeted. Now, like any HR or benefits professional, I'm not going to say I never get any phone calls or complaints about things. That's part of the nature, especially when you're managing a plan of people in the hundreds of thousands. But the amount of noise on this is basically went away because it's seen as value, and it's all in how you do your change management, right? When you help people understand why these changes are happening, then all of a sudden they say, oh, this makes sense to me.
I think one of the things that's really resonated with me as we've, essentially tried to download what you are doing into our playbook is how good you are at articulating the what's in it for me for the member. Like that's what we seize on, is just focusing on the what is in it for me. It's money back in your pocket. It's access to the drugs that you need, and then it's lowering your overall spend because we're spending our money more wisely. So couldn't agree more. I think so we've got these two levers, right? You're making the pitch to HR leaders on this call who have 300 people. They might be like the benefits manager, the recruiting manager, they're wearing every single hat. And we're saying, hey guys, like going into your next renewal cycle, go like interrogate your PBM contract and improve it and cut out some of that. And then we're saying interrogate your formulary and do a higher performing formulary that gets you the right outcome for lower cost. And they're probably saying, I've got no freaking time and no interest in becoming an expert in PBM. So maybe we can talk about I want to unpack this. What is the first step an employer can take if they're like, yes, I would like 10 to 20% savings over the top, but what can I do here? I'm not going to become a PBM expert. What's your perspective there?
Yeah, so it's a super question. And, with regards to the contract review, I think that's always a first step. I mean, because to me, that's the easiest thing that you can do. And that I'm going to circle back a little bit to, it's worth your time to invest and find a trusted partner that's going to only be looking out for your interests. And, now can serve that role as we continue to talk about the best ways to do that. But it can be, you need to find, my point is to find a trusted partner, right? I mean, we're a huge company and I do have a staff that works on this stuff, but we went out and we found a trusted partner that I know only looks out for my best interest and has deep expertise in some of this stuff. And so that's what I encourage folks to do and to do that. And so if I'm you, I'm going to next phone calls to Brandon and start bugging him. But
no, I love it. I mean, this is what we do. But what I would say, to the skeptics on the call is that this is one of the functions that your benefits broker should perform. And so there's just a very straightforward question that you can ask it, because pretty much every single person who's an employer on this call has a benefits consultant or broker partner, which is come back to me with a proposal on how we can level up our PBM contract and the performance of our formulary, and put this ball into their hands. That is absolutely where that ball should be. You should not have to become a PBM expert. And then there's various mechanisms. I mean, we've spent a lot of time in this space and kind of built out a set of partners that we utilize here. And I think that this needs to be an annual point of interrogation when you're reviewing your overall benefits plan. And it's if you haven't pulled these levers yet, you can do it for the upcoming renewal. And I feel very strongly that you can deliver savings back to your members if you do that. I think if we were to kind of recap the two levers, we're talking about trimming the fat in your PBM contract, 5 to 10% savings just off the top, higher performing formulary that's replacing those expensive drugs that provide no additional medical value beyond lower cost drugs. And the range of savings there, 5 to 15, maybe even 20%, depending on how aggressive you get. Todd, when we kind of talk about maybe like next steps, right? So the goal of this conversation was to get the pharmacy and PBM conversation started with HR leaders, get some first steps, low hanging fruit, make sure that they know kind of where they go to like get that ball rolling, which is go to your partner. They should be driving it. that's the one-on-one conversation. But as you and I both know, we've got kind of much larger ambitions here when we think about, cutting the cost of pharmacy. Todd, do you want to maybe touch on some of the things that we hope to do in the future as we think about 201 and 301?
No, yeah, I'd love to, Brandon. So sometimes I get asked the question when I'm talking to Brandon or some of the Nava team and say, why'd you agree to be an advisor here even? Because you don't use a broker necessarily at Caterpillar. And I said, well, the answer to that's very simple, is that I am passionate about getting rid of waste in the U.S. healthcare system. Because to me, it's a little bit embarrassing how much we spend on it based on the outcomes we get. And so we got to find better ways to do some of this stuff in a great country like this. And so I said, I find that when I talk to folks, it's the small and medium businesses that really struggle with being able to execute stuff like this. And I'm interested in helping Nava find a way to make that scale happen. So in other words, what kind of things could we put in place that you could say, hey, Brandon, I don't really understand formulary, nor do I want to. I don't know anything about a contract. And when you said AWP, I have no idea what that even meant. But boy, I sure would like to save that money, and that we would have more of a turnkey kind of solutions that we could turn on, that we could use the scale of the Nava book, but apply it individually to companies. And so that's some of the stuff that I think that we can develop and we'll continue to work on. One of the things I talked about today, that stuff can start to happen immediately without a 2.0, and that's the kind of services that Nav is going to provide and help you do those things. But to do it to the next level, that takes a little more heavy lifting to make that happen. But that's what I envision us we're doing here and pulling off, is to bring what I have the scale to do as Caterpillar to small and medium businesses, so they can have that same scale and have those same kind of results without having to have 100,000 lives to manage.
Exactly. Yeah. A lot more there, but that's kind of what we've got cooking in the lab, which is how do we productize a lot of these levers that go well beyond the kind of 101 low hanging fruit mark, and bring them to essentially a book of business that's essentially a group of small and medium sized employers. So we love the power of banding small and medium sized employers together, and kind of bringing the strategies there. So we'll excited to talk more about that. Todd, we got a bunch of questions in too that I wanted to wait until the end, because some of them are pretty detailed about kind of into the details. I think one question that I think maybe I'll start with, and then we'll get into some of the details maybe around your perspective on RX strategy. Someone said most brokers have no clue what a good PBM arrangement looks like. I'm smiling because I agree. They chase shiny objects and don't have the depth and resources to understand fiscal and contractual mechanics. So question is, are they being paid by the PBMs and BUCAs not to do what's right for the client? I think is maybe the question. I'll tackle that. And I think without throwing folks under the bus, I think the reality is there is some real complexity there when it comes to unpacking just the kind of the nature of the PBM contract, formula. There's a lot of domain expertise there. And it is true, I think, when, from a kind of a BUCA, Blue Cross United, Cigna, Humana, kind of the big carriers, they definitely financially incentivize folks to kind of stick with the status quo. One thing that we talk a lot about is it turns out, the right plan can save a small or medium-sized employer 20 to 30%, but it actually pays the broker probably 30% less than the wrong plan. That is just a true statement. And it's actually a lot more work to stand up for the broker, but that's the right thing to do. So I don't know if you have any other observations on just why this is such a mystery for small and medium-sized employers. Why is this not already happening right now?
Yeah, and so, specifically to your question, the other thing that I see happen a lot is what I call spreadsheet RFPs. In other words, there's not a lot of deep subject matter expert behind the broker, what the broker has, but they do have a nice little spreadsheet where all the people they ping the market with can plug in their numbers, and then they spits out the bottom. Then it becomes a spreadsheet exercise. Well, you take this one down from 1 to 99.99, and that's just, again, allowing the PBMs then to get those numbers in there, and then they just start cranking all their levers on the back end based on the contract language they can put in place. And so that's why I think you don't do it. And as a result, what usually happens is it comes out of that as the broker will say, hey, guess what? We saved you 3% here, and no one's ever got fired for saving 3%. And so the game continues. And so instead of saving 8, 9, 10%, you saved 3,
Yeah.
but you didn't get fired for it, and you didn't know you could have saved 8 or 9 or 10. And so that's how the game continues.
Yeah, no, I think that's a fair characterization. I want to hit, we got about 12 minutes. I want to hit some of the questions that we got in. This one from Kristen, pretty high level, but she said, what is your medical RX strategy? Probably talking about yours at Caterpillar. And specifically, is there anything outside of the box that you're doing?
Super question. And so I can't, some of it I can't say more than yes.
Yeah.
So I do have some really interesting things that we're working on right now that I can't really talk about yet. But medical RX is a big challenge, right? Because it's not as easy to manage. It's sometimes bundled into things, and you got to really get into the right data. And so, you know, how do you get it right? How do you adjudicate it the most efficiently way? How do you get the right protocols to happen in these settings? So there's a lot of challenges there, and I'm not going to claim that we've figured them all out yet. But there are some things that we're working on that I think are going to be pretty unique, and I even think some of them are going to end up being scalable and innovation that can come down to the small and medium business level. But I'm not there yet. It's not out of the bag yet, if I could say that. I think it's something that's got some real potential to look at a different way of purchasing and then utilizing some of these kind of medical drugs that end up more on the medical side than on the pharmacy side.
Yeah. It's maybe I want to hit a question from David. You said, do you have input into your company's criteria, PA and ST? Does your PBM allow your clinical team to customize it? It's getting into some details, but it's an important detail.
No, it's an important question. And if you back to what I look for in my PBM contract, flexibility was one of my 2 big ones, right? So we write our own PAs, we write our own step therapies, and we always start with what they're doing already, because we're not trying to reinvent the wheel if we don't need to. So we look at what they're doing, but then we make our own decisions on how we want to cover stuff, what tier we want to put it on, if we want to step it, if we want to PA it, if we want to exclude it. All that is done by our clinical team. So yes, we do all that ourselves, and then we tell them how to administer it. Yeah.
Cool. Thanks, Todd. We've got another one. So the question is, what is some innovation that you've seen in the RX or PBM space that's got you particularly interested or impressed? Right? There's a new set of PBMs, anything that's really particularly exciting to you?
Yeah. And so what I'm watching kind of closely now is where it's going to go. It's almost like a cycle where what PBM started out as is really what they should be. And in reality, to be a PBM, you need a call center and an adjudication server. And so I think you're starting to see some people recognize that and start to circle back that way a little bit, and be able to let folks like us, the folks on this call, say, hey, you know, the strategic stuff is what we want to care about, you know, but we don't want to deal with call centers and step therapy authorizations and claims adjudication. So use call center and server people, take care of that, and we'll do the rest of this, and start to get the model back to what it used to be. So we're not always fighting with these big PBMs and have all these different crazy models, but going back to what we did. So that sounds pretty simple, but sometimes simple is what can save the day. And if we can start to take control of that stuff again, that I think would be really interesting. I also think that, you know, there's continues to be more and more movement into the space of being able to accurately educate people quickly at the point of service what they need to challenge people on. So that would be better. So that way I wouldn't force me to force have to do it all through plan design or through this other stuff. If people have better information, I think people want to make good decisions. But they just don't have the data at their fingertips. They're not comfortable challenging their doctors, and I don't blame them for that, right? I mean, and so
couldn't agree more.
Yeah, and so I think those are a couple of things that are evolving that I think could make a difference in the RX space in the future. We'll follow some of the high tech stuff around gene therapies and, you know, all the explosion of specialty drugs and, you know, all that space there's some interesting stuff there too, but that's a whole nother can of worms.
Yeah, no, we're spending a lot of time with what I would call the modern kind of tech-enabled and employer-aligned PBMs, you know, Capital RX, Smith RX, or a couple of them. And you're absolutely right. There's kind of two major job functions. One is adjudicate claims, and how might we start adjudicating claims with a little bit of intelligence around that adjudication process. And then number two, how might we just kind of go back to basics in terms of aligning the compensation model for the PBM to like what they're actually doing. So getting completely away from spread pricing and AWP and that just entire like, I'll give you 80% off of any price so long as I can set the price, just total bullshit. Yep. Toward just a kind of flat fee based thing. So we're really excited about that. That's something we push our clients, especially when we do PBM carve outs and move into a self-insured arrangement with clients. Interesting question. We got a handful of other questions I want to get at. This one coming in from Barry. Barry said, is there anything that you can share about where Caterpillar is with regards to the traditional PPO network approach and their discount price modeling versus a value-based arrangement, whether that's with providers and facilities? That can be centers of excellence, direct contracting, bundle pricing. And I think it's a great question. It's something that we're spending a lot of time on. We think the network is one of the fundamental broken elements of kind of how we're approaching pricing. Maybe even abstract at higher level if it's not about Caterpillar. Like what are you seeing? What should employers be thinking about in terms of moving away from that toward a better approach?
And so the medical side of the house has just as many, if not more, challenges than pharmacy. The reason I always counsel people to start with pharmacy is because it's much more of a commodity than the rest of medical. And again, if you're a pharmacist or a PharmD, don't be offended. They always hate it when I say that.
You're not a commodity, but the pill is.
It's not a commodity, but it's closer to a commodity than healthcare, than broader healthcare is. But some things apply in that space. So Caterpillar has our own PPO network that's based in, the largest percentage of the population is in Illinois. We have employees in every state and all over the world, but and so we do have our own PPO network in Illinois that we do all the contracting. So we direct contract with, 30 some hospitals and 3 or 4 or 5,000 doctors and specialists, where we have a direct contract with them. And, I'm not going to go into the numbers there, but let's just say people say, why would you do that? And I said, if you saw my books, you'd know why I do that. So it all comes back to the same thing. There's waste in this because people can't get their head around, how could you do better than United Healthcare in this contract? I said, I do. So it's the art of the possible versus the art of this can't be right. And so there's a lot of stuff there. So now what's lacking, I know we're running out of time, so I'll be quick, is finally now getting to the point where I'm a little more comfortable with the kind of quality data we have access to. I've been people for a decade to get quality data consistent and not have 1,000 different methodologies and to have stuff that we get comfortable with to steer our membership to. And when that hits and we're getting really close, then bam, we have the holy grail. We're going to contract, we're going to have quality, create a value network, and we're going to incent people to go there. That's where it needs to end up.
I love it. What's a recommendation for Barry on how they can think about, as a smaller, medium-sized employer, think about doing some version of that, right? Direct contracting, accountable care, center of excellence. What might they do?
It's probably easier for you to try to look at some of the center of excellence models because you can just do a contract there that's kind of already pre-existing. And if you can find some, best in class type of centers of excellence, there's a lot of challenges with too. They're not all the centers of excellence aren't centers of excellence. So you really do a little due diligence, but it'd be a lot harder for you to go and do a direct contract and build a PPO network as a small company. The only exception to that would be if you're 300 people or in a medium-sized city and you've got a provider there that values that business, that's where you have leverage. They don't want to say, oh, we're the hospital that doesn't do business with company X, if that has any say in your location. So it's a little specific to that.
Yeah, that's great. There's another lever to pull there, which is and we're partnering with providers that are taking the data that Todd is talking about and essentially identifying the highest performing, kind of lowest cost providers inside of a larger network and getting access to what we call kind of a high performance network inside of a network, kind of gaming the system to a degree, but pointing employees to folks who have better readmission rates and outcome rates. So more there. Happy to email me directly if you want to dive in more on that. But I think there's a lot of meat on the bone there. Todd, actually, just last maybe two quick questions. Do you know of any PBM using an acquisition cost index business model versus AWP discount?
So I don't want to name any specific PBM names, but what I'll tell you is that there's a lot of them out there now that are willing to look at other pricing models.
Yeah.
So, and there's more than one way to address this, even if you're stuck at the AWP. I mean, there's AWP fences you can put up. There's lots of different ways to do it. And they don't talk about it ever. But like I said, if you're asking for what you want them to, what you want to buy from them, they'll volunteer it then, but they're not going to tell you about it up front. So you just got to ask for those kind of things to make it happen, because they're out there doing it. They just don't talk about it.
I love it. This is great. I think we've got a minute to go. I'm going to wrap up. Todd, I'm going to get to your question offline. It's around legislation around PBM transparency and what we do. I want to wrap up real quick. Just thank you everyone for being here. Really appreciate you taking an hour of your busy schedules to join. If you're interested in more advanced content on this topic, if you want to start pulling more levers there, we're going to do a deeper dive in the near future. And frankly, going into that, we'd love feedback or questions you'd like to see us address and tackle as we think about putting that together. Also, if you're an employer and you're like, I'm curious about how I can save 20% or more on pharmacy with some of these levers, but you don't know where to start, we're doing a complimentary pharmacy assessment. We're basically we'll take a look at your existing PBM arrangement and identify spots where you can save. You can email me directly at brandon@nava.io to set that up. And we're also going to start a version of executive office hours with our advisory board, including folks like Todd. So if you're interested in being included in those, email me or reply to the email you got. We'll add you to the list. So that's that. Todd, thank you so much for the time. Really appreciate it. And I see this as a kickoff to a much deeper thread here around how we just cut the fat out of pharmacy for small and medium-sized employers. So really, really appreciate your time.
Well, thanks for the good questions, everybody. And it was a lot of fun.
Great session. Thanks, everyone. Have a great day and have a great week.
Have a great one.